Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this morning I'm with Brad. How you doing today?
I'm good, man. Good to see you again.
Yeah, very good to see you. So, working at the schoolhouse, training, and especially this newer, generation of medics are completely and utterly petrified of longer acting opioids like morphine or hydromorphone. So based on your experience, you're the perfect guy to talk to about this. So, can you tell me just a little bit of your experience with like morphine, hydromorphone?
Well, I mean, obviously back whenever I came in, back in the beginning of the 90s, everything really was back then was morphine. The thing that wasn't around back then for people was, the ketamine and especially fentanyl, back then. And, back then it was actually very taboo kind of a thing. So everything was, pretty much morphine based, and, even Dilaudid wasn't, something that you saw. It was people knew morphine, and that's pretty much what they knew. And then, later on, I was kind of the driving force with a lot of the getting people to switch over to, ketamine, especially in the trauma environment, and using that in different ways for procedures and things along those lines. And also, pushing a lot of the fentanyl, IV fentanyl, even more so than, the fentanyl lollipops. But I think, as we've talked about in the past that, at times things start to swing almost the other way, and people start to want to throw the baby out with the bathwater, and say like, well, I can never use morphine because it's an old drug. I can never use Dilaudid because it's an older drug. And that's not the case. It's like, I always try and tell people is like, use the right tool for the right job, type of a thing. You don't want to use a hammer on a screw. Yeah, you can do it. It just isn't going to turn out real great. You know what I mean? And you're going to tear a lot of stuff up. But the point being is that, everything has a place, and a time, and, getting people to realize that, because, a lot of times, we were dealt with, very limited resource environments, and maybe I don't have any more ketamine, unfortunately, and I only have morphine or Dilaudid, or maybe I'm down to something like Nubain for some reason, Demerol, even if I'm in other countries when I'm having to buy things off of the economy, type of a thing. So I think, from that standpoint, and from teaching guys for, forever, is trying to think through, here's what I have. How do I do that effectively? And is it make sense for that situation, kind of a thing. So yeah, that's a little bit of the background from it.
So yeah. Just, since you were there when the switch happened, I guess, why was ketamine introduced? Was it because everybody was dying from all the morphine that we were giving, or bad outcomes? Well,
I think, people, we've talked about morphine in the past, and it's kind of the original, so to speak. And the older a drug is, we always say that it's more of a dirty drug, meaning it has more of the side effects that we don't want. And in a trauma environment with people that are hypotensive, from, obviously from blood loss, and, it is not a great trauma drug in that setting, especially with somebody who's unstable, because of the histamine release and the drop in blood pressure that you can see from it. And so what are better options, in that environment, especially if I'm having to do a procedure? And so getting people, a lot of the things back then when a lot of that started was, well, I need to do things like I need to do a crike, or I need to do a chest tube, or I need to do something. And morphine takes so long to actually start working. One of the dangers was tied with the histamine release and a drop in blood pressure is people would never give it enough time to work, and they would get anxious and start adding more and more. And then it would build up, and you'd have a more of an exaggerated response, especially with a drop in the blood pressure, that, it's not a good option in that environment. Ketamine, because it works so fast, and because it has very cardiovascular stability, especially in the face of like, hypotension, and then also fentanyl being very cardiovascular stable, were much better options, as far as, especially in doing a procedure, things along those lines. So that's what was the driving force, also because of some of the procedures that medics were being taught, at that time, in my environment, back on the compound. They needed a way that was a better option than just morphine. And so that started a lot of that driving force on the techniques and the procedures that we were developing for that. And then a lot of that started to get out to the bigger force, through the schoolhouse eventually. You know how things do. It starts to get out. And interesting enough, when it started to get out, people were like, whoa, what kind of black magic are you guys doing? It's like, no, man, and now what was black magic back then, I guess, is, the accepted, which, how things go around. So,
I mean, the best evidence is, does CAG do it? And if they say yes, then obviously that's the best way to do it.
Yeah. But, so, but again, I think the more that it does, get out to the bigger, the rest of the military, some of that, why it all started and what the reasoning was from behind that, gets lost over time, what the driving force was. And even with all of that, it was still never, oh, well, let's just throw all the morphine away or the Dilaudid away. That wasn't the idea. It was like, let's use this in a way. And then, a lot of what we were doing back then too was, I've done my procedure. The person is stable. Now I may be sitting on this person for a long time. I've only got so much ketamine to use or fentanyl to use. And now I'm looking at long-term pain management of this person. Is it safe, and can I do it in an effective way to, manage my resources, because I've only got so much. Now to do something like, can I transition this person to morphine, maybe Dilaudid, to get long-term pain control now that I'm outside of I need to do a procedure type situation. Now I'm just managing pain for a long period of time, whether that's, 24 hours or maybe 36 hours, whatever that is. I don't want to, keep, hitting them with ketamine over and over again, because it doesn't last very long. And the other part of that is I only have so much. And a lot of times what people don't talk about enough is that people see ketamine a lot of times as they've done it one time, they've given one dose, but they've never had to sit on the casualty that they repeat that dosage over and over and over again. And the problem with that, with ketamine, is that's why I always talk about, you really do need at least a couple of milligrams of Versed up front with ketamine, because, they talk about party dose and, partially disassociated versus disassociated dose. Yeah, that's fine. But when you start talking about total dose of ketamine, once you start to build up the total dose over that 24, 36 hours, you're going to get some of those, untoward, kind of dysphoria type effects, the more the actual total dose starts to build up. Once you start to get up around a total dose of like 200 milligrams, 300 milligrams, that party dose and all that other stuff, that's out the door. They're not tripping because of, they're tripping because of the total dose has reached a level, and, that's just something that I don't think gets talked about enough. So if I'm in an environment, if the patient is stable and I don't have to keep dosing them with ketamine now, and I'm able to transition over to morphine and dilaudid, it can be a much better option long-term, than keep hitting them with ketamine over and over and over again, cause trust me, there's no other person on the planet that believes in ketamine more than me. Okay. That's why I pushed it forever. But again, teaching that for a very long time I taught it in a very specific way to help guys understand why there's Versed with it and why, when I can make that transition over to something else, it makes more sense, to manage the resources, but to also manage, what that person may start to experience, with that buildup of the ketamine dose. So anyway,
And also, like you mentioned, when it gets out, I mean, it's not like a secret, but like once it gets out into the, more mainstream, I guess, you're not always having it's not always you talking to every group. You know what I mean? It's somebody who has probably less experience doing it, repeating most of what you said, and it just keeps getting diluted down the road and I'm just guessing your initial thought wasn't, as soon as I gave my first dose of ketamine, I also give them my dose of Versed. It doesn't seem like something that you would have said.
Well, for me, a lot of times it was up front, and we're not talking low dose ketamine right now. We're talking, okay, I'm going to do a procedure.
Right.
I'm setting a femur fracture or,
surgery.
whatever that procedure is, right? I'm not talking about like the 25 milligrams where I'm doing it for pain control tied in with my fentanyl lollipop or that. The Versed was, I know that I'm going to be giving a larger amount of ketamine and I know I may have to repeat it a few times. And so in those instances, the best answer was, for adults, it was 2 milligrams of Versed to start. And then I went with my ketamine. And that way I kind of had some of that coverage of having those untoward, going down the rabbit hole with the ketamine, side of the house. And that's where a lot of that came from. But no, you're right. And the other problem too was, again, if you haven't done it in the field and you haven't done it over periods of time, then a lot of the information was coming kind of more from the emergency room side of the house. And that's fine. However, in the emergency room, worked a lot of emergency rooms. Okay. The problem, if you're only taking that side of the house from the emergency room is, again, that typically is, I'm only doing this one dose of it and I'm not having to redose it over 24, 36 hours. And so people a lot of times will tell me, oh, I've never seen that with ketamine. I'm like, well, no shit, because you did it the one time and you don't have any experience in doing this over a longer period of time. And your sample size is you saw it like 2 or 3 times and you're an expert. It's like, yeah, no, dude, that's not a thing. That's a data point. That's not, that's not trend. And that's not, long-term experience on seeing what happens, with patients and casualties. And again, the other thing is in the ER, it's not, like it or not, you're in a controlled environment. I know a lot of people like my age aren't a controlled environment. Okay, dude. It's not.
You haven't seen uncontrolled.
Yeah. It's not in a tent in Somalia. Okay. So it's not the same thing, so again, I don't want to get on a soapbox or go down another rabbit hole.
Sure.
But getting people to understand, what you may be dealing with, as a medic. And I know you see it a lot, from the refresher side. You're having guys come through and they're just, it's nothing against them. They just haven't had the exposure that guys were getting 15, 20 years ago when the war was really raging and they were seeing a lot of different things downrange with a lot of different deployments. Now guys, I'm sure, are coming through refresher and they've never even been downrange, and they just don't have as much exposure to a lot of those different things. So, I think that's where institutional knowledge a lot of times, gets lost, and you're just the old crusty guy in the corner preaching. You know what I mean?
That's right.
Because
that whole Walker dip is a thing.
Yeah, dude.
But another thing you mentioned, and I'm really glad you did, like context is super important when you're talking about like a technique. Like you mentioned, I'm going to use a large dose of ketamine. We're going to do a procedure. I'm also going to throw in, 1-2 milligrams of Versed with that. Mm-hmm. Because I know exactly where they're going and I know exactly what is going to happen. This is what's going to be required for that. Very, very frequently, somebody will be like, I'm going to give him 25 milligrams of, ketamine, and I'm going to give him, 2, 3, 4, 5 milligrams of Versed, and like with it, and like one shoulder, the other shoulder, and it's like, how do you even know if you've taken care of this guy's pain or not?
Yeah.
Like you've sedated him, and you know what I mean?
Yeah.
So I try to tell people, context is always important when you're talking about like a technique to do something.
Yeah, absolutely.
But that absolutely makes sense as far as like the depth that you were taking those patients. So let's say, another thing you mentioned is, transitioning from these rapid acting agents, whether that be ketamine or fentanyl, and transitioning to a longer acting agent after the dust is kind of settled on what's going to happen to this patient. They're in more stable position, and now we're doing more longer term care, making sure this guy stays stable until some kind of evacuation, right?
Mm-hmm. Yeah.
So let's say I've been sending ketamine, mix of ketamine. We have a little bit of Versed in there. There's probably a fentanyl lollipop at some point. How would I leave the spot of like relative comfort and now transition into the devil's medicine of morphine? I'd say morphine is probably the scariest, I guess, of morphine or hydromorphone.
Okay.
How would one transition?
So again, all right. I don't want to say easiest, but the best markers typically whenever you're using narcotics with patients is respiratory rate. Okay. Obviously all your vital signs that you're looking at are going to be important, but the one that I try and get people to put at the top of the list as they guide, any kind of, pain management with, opioids is respiratory rate. So, again, a lot of times, there was also a perception where if with the guys like, well, I've given ketamine, I can no longer transition over to like morphine or Dilaudid. And that's just not true. Okay. But what you need to understand is when I look at the respiratory rate, typically, the number is they're comfortable if they're kind of in that 8 to 12 to 16. They really probably don't need, you to redose any type of an opioid at that point. If you have trouble with some of the numbers, 10 to 20 tends to be numbers that you can remember pretty easy. So if the respiratory rate is between 10 and 20, they really may not need anything. And one of the problems, a lot of times is, us as providers, we look at somebody on the battlefield and how bad the injury is. And we look at that and we see ourselves and we're like, oh God, this guy needs something. Cause if that was me, I'd want it. It's like, no. What is he telling me he needs? And I don't mean verbally. I mean, what are his vital signs telling me he needs? Now, as he starts to, if I'm making that transition, I've done my procedure, I've done ketamine, I've used maybe some IV fentanyl. They've had like the 2 milligrams of Versed. What I'm really looking for, and in my mind, I'm saying, okay, I need to save the ketamine and the fentanyl for other things. I want to transfer over into the morphine or dilaudid zone. Then I'm looking for that respiratory rate. Once it starts to go up to close to 20 per minute, now I'm thinking, okay, I'm going to start to add in my morphine or my dilaudid. Now, if we kind of remember back, if you get kind of the equivalent dose, and it's not exact, but if you're trying to remember this, 50 micrograms of fentanyl is about the same thing as 5 milligrams of morphine is about the same thing as a half a milligram or 0.5 milligrams of dilaudid. Okay. The other part of that is, as I'm making the transition, if I'm doing a transition, I know they already have some pain control on board. Okay. So I'm not starting from scratch. Okay. So if I'm making a transition, and I'm talking about IV right now, I'm not talking about IM. Typically what I'm looking to do is IV morphine, 2 milligrams as they're reaching up to that close to that 20, and see how well that works. Now, all I'm trying to do is get them back closer down to the 10 breaths per minute. Okay. Now, the other part of that is I got to let it work. You got to remember, morphine takes, just the onset of morphine IV is 5 to 10 minutes. Okay. The peak effect really isn't for about 15 minutes. So give it a chance to work, give it the 15 minutes, and then see if that respiratory rate's back down around 12 or 14. If it's not, okay, now I'm going to give another 2 milligrams IV. Okay. And I give them that 15 minutes and see if we're back under control. Understanding like IV morphine, the durations, about 2 to 3 hours, depending on how their body's functioning. If I'm trying to do it IM, then I typically kind of double that dose, or a good number a lot of times is IM. I'll give them like 5 milligrams of morphine IM. If I'm in a transition now, again, they've already had some narcotic on board. This isn't starting from scratch. Okay. Because a lot of time, back to context, people get those things confused where they're like, if I've done nothing to this guy, he's had no pain control at all. Let's say it's a femur fracture or shot through the leg or whatever it is. And I've only got morphine, then I'm using a bigger dose up front, but that's not what we're talking about right now. We're talking about they've got some pain control on board. The other great thing about ketamine, and the reason that one of the big pushes we were driving with guys with ketamine, was because it typically lowers the narcotic dose that you need long term. And so my 2 milligrams of morphine, if they've had ketamine prior, is going to work much better than if they had no ketamine on board and I was using my 2 milligrams of morphine as, from scratch. So that's the other reason. Like, I don't want to just go full bore as I'm making that transition. It's because they've got some pain relief on board. I'm just trying to modulate that into a longer term situation and stretch out my narcotics, that way, so that's kind of a gist on how I would do it. But respiratory rate, honestly, is the key. A lot of times, people, and this happens in the civilian world all the time. It's like, new, recovery room nurses, as people are coming out of the operating room, a patient may lay over there and they're like, oh, I got to check, vitals every so often. And one of the things they ask is, and the person's like totally asleep, they're breathing like 8 times a minute, and they go in and they're like, oh, excuse me, how's your pain doing? They're like 10 out of 10. And then they fall back asleep and they're like, oh, I got to give them some more drugs. You're like, no. It's like, look at what the respiratory rate is. It's not so much, cause, and especially, I hate to say it, pain's cultural in a lot of ways too. It's an expectation thing, so if you ask patients, coming out of surgery, what's their expectation? Well, my expectation is no pain, so I'm going to tell you it's 10 out of 10, even if it's, I don't know, 2 out of 10, So you got to look at, or nothing, you got to look at the vital signs. And one of the very big ones, that I always try and drive home is the respiratory rate. So yeah.
Yeah, absolutely. I think that's another concept that really hasn't taken off that well, at least in our community, is like patients earn their narcotics.
100%.
And it's not like they earned it with their valor. They earned it with their vital signs. Are they stable enough? Are they perfusing well enough? Are they oxygenating well enough? If they are, by all means, I'm a giver. You earned it. I will give it to you.
That's right.
But if you didn't, I'm not.
Yeah. Well,
not because I'm cruel, but because if I do, it's going to get a lot worse already.
Well, and again, I always tell people, don't help your casualty over the edge of the cliff. It's like, you don't want to push them over the edge. I think I lost you there for a minute. Okay. Yeah. All I was saying was like, don't help your casualty over the cliff, don't push them over the edge, that kind of a thing, because, again, that happens, so they have to, you're absolutely right. First, they get nothing until they can prove to you through their vital signs that they can handle it and that they need it. I had a great instructor, way back in the day, tell me, bad memory is better than no memory, meaning they don't have a memory because they died, kind of a thing. So, don't help them over the edge, and that's very important for people to understand as well. So yeah, absolutely.
So let's say we've accomplished this, right? We've transitioned successfully from our ketamine fentanyl mix, right? Into like, morphine or hydromorphone. Okay. Now comes time to transport. You're going down bumpy roads, vibrating helicopter, choppy water, like regardless, like the patient's pain level is going to increase, and probably not in a consistent way. So is it okay just to keep, since I'm on morphine, just keep bumping them up and up and up with my morphine, or should I, or can I add anything else to this?
Well, I would stick with what you've got. And another part of that, when we say transport, is, am I going with them, or am I handing them off, or am I handing it off to somebody? I'm saying, mentally, cause a lot of times people would do something like, if they were getting ready to hand them off, they'd hit them with something and then they'd hand them off. And then the guy who they handed off to doesn't really know what just happened. There's a lot of AARs out there where things like that happen. And then, the poor medic on the flight or whatever else was like, what just happened? This guy was fine 10 minutes ago. Well, that's one of the reasons. But, I'll take a step back too, when we were talking about, they got to prove to you that they need it, type of a thing. Talking to the casualty is massive. I have talked a lot of casualties through things without pushing a single thing, because that's all they could tolerate. And if you talk to people and let them know what's going on, instead of it feeling like the guy just feels like he's being assaulted by you, instead of like an active participant, if he's conscious, obviously, but talking them through what's going on, using the power of that, we used to call it okay anesthesia, where you're sitting there being like, it's okay, man. It's okay. The power of, touching the patient, putting your hand on their shoulder to let them know that it's, what's going on. You're telling them what's going on, it's just a huge part of all of this that we just, it's been lost in the sauce again with a lot of these things. But again, yes, if I'm close to that window, again, I'm looking at respiratory rate. Well, if they're breathing only 10 times a minute, I'm not giving them anything yet for the ride, just because we're getting ready to ride. if we start to ride and they're pretty soon out of the gate, their respiratory rate picks up, and I typically, well, sure, I'll give it to them then. Versus, let's say I know we're getting ready to take a ride, whether it's a vehicle ride or it's a helicopter ride or whatever that is, and they're up towards getting close to that 20, meaning the drug's wearing off. Well, yeah, then I would look at it and say, like, let's go ahead, give you that redose. Okay. And we're going to start moving, because I know it's only going to get worse, at that point. So it depends on where in that spectrum I am of that 10 to 20. If I'm way down here at the 10, 8 to 10, they're probably doing okay to start that movement piece before I need to redose, kind of a piece. So that's, again.
Let's say, take tactical situation out of the window here.
Okay.
Cause that can throw a wrench into anything.
Oh, yeah.
But, let's say we have control over when we leave for our evac, right? Yeah. He starts waking up, we dose him, we wait till he gets settled back in, and then we can proceed forward. Is that the idea? That's the ideal?
Or, that's the ideal. But even then, let's say I don't have that time, like, I don't know, you think the bird's so far out from landing, and whatever, monkey wrench gets thrown into that. But I go ahead, like if he's at that upper end, that respiratory rate, and I go ahead and dose him, I'm not going to wait. If the bird comes in the ground, I'm not going to be like, oh, hey, hold up. No, we're going, I just know that, again, I'm not handing him off. I'm doing it. So I know what I've done. I know what to look for. I'm looking at my watch, how long's it been since I gave that dose before we got, because like I said before, that movement piece, we know that that's going to cause something. But what I don't want to do is I don't want to dose him as that bird, is coming in. Then I start to move him. It hasn't had its full effect yet. Then I get him onto the bird. Then he starts, and we haven't even left yet. His respiratory rate picks up just because we're moving him and stuff. Dose him again right off the bat. Oh, it's not working yet. No, let what you did work. Then make that decision, once you've settled them in, and, cause that little piece, unless they're freaking out for some reason, you got to let the meds work. And again, when we're talking about morphine and dilaudid, the problem is people just don't give it enough time to work. And then they start bumping again, when they didn't have to. Again, the patient's not, is this killing this guy, or is he just uncomfortable at the moment? And it's like, okay, it's uncomfortable for the moment. That's where you talk to him, tell him what's going on, get him to be an active participant in it. It's going to be all right. We're settling in here. If those drugs I gave you a few minutes ago aren't working in a few more minutes, I'll give it to you again. And chances are they're going to start working. He's going to be calmed down. He's settled in after that little bit of movement. Okay. That kind of piece. Vehicle, helo, even walking. We're walking out of here, man. You know what I mean? And this is going to suck for a little while, so, but.
If you don't mind, let me tell you my idea.
Yeah, sure.
And then feel free to say that's the dumbest thing I've ever heard. But, so I guess what I was thinking, and I've done it, and at least so far it's worked. We get this guy settled in, right? He's gotten his dose. I know that things are probably going to get worse once we start moving, whether that be choppy water, whatever the reason. He starts bouncing around, and that respiratory rate starts picking up, versus hitting him again with like a longer acting agent, adding like a shorter acting agent like fentanyl or whatever the flavor it is you feel like you can control the best, put, small bumps to get that part under control. Cause my thought was once we stop, if I've kept hitting him with my longer acting agents, once that movement stops, then he feels, the effects of, this much higher dose with a lower stimulus. I don't know. Does that make sense?
Yeah, in a way. And so again, when we're talking shorter acting, and this is where, another thing we need to talk about too is IV versus IM. Okay. Because, if guys were using IM and the movement piece goes from a colder environment to a warmer environment. So let's say I've been on the ground, the helo's coming in, there's heat on the helo. They're going to start warming up. They are going to start metabolizing that drug that was given IM that may not have been working at all on the cold ground. Okay. That's another huge piece of this. That actually happened quite a few times in Afghanistan early on because, they were hitting them IM with morphine, hitting them IM with more than hitting them with it's not working. It's not working. Yeah, it's not working because they're so cold. The blood's gone to the core. It's not feeding the muscle. They get them onto the helo. It's an hour flight. They warm up on the helo and then their body starts getting all of the morphine from that same. So part of it is the route that you're using, meaning IV or IM, right? The other part of that is what do I have that is short acting to get them through this little portion of this, ketamine's actually a very good option in that. I mean, it is a great option in that for a couple of reasons. Number one, it's working through a different pathway than the fentanyl would be, which is working the same pathway as the morphine. Two, it actually helps respiratory rate, not decreasing the respiratory rate. And again, it's going to cut my narcotic use in theory, about in half. It works very fast, but the other thing is it starts to go away very fast. IV, ketamine, as far as like, things like respiratory rate and effects on BP and heart rate, it's about 7 to 10 minutes. It's gone, so it is a great option in that scenario to not have to give them more morphine, but to just give them a little something like a 25 milligram dose of ketamine that's going to help the morphine work. It may get them through that little brief amount of time that you're talking about that I don't have to. And again, it's not going to mess with the respiratory rate, which is the big thing I'm worried about with that morphine. Okay, man, great call. If I use fentanyl, I can also do that, but I'm definitely going to decrease my dose of fentanyl, understanding that it's going to have a bigger effect on the respiratory rate, which is a concern. It's very cardiovascular stable. That's great. It works very fast within about 60 seconds and it peaks within, 3 to 4 minutes and it's going to be gone in an hour, type of a thing. So that could be an option, but it does have a little bit more of the danger side of, especially with the respiratory rate of, getting me well below the 10 breaths per minute, boom, kind of thing. Whereas the ketamine is a great way to go because of the fact it's not going to affect the respiratory rate like that. It actually promotes respiratory rate. It's even more short acting and it can get me through that little window of time that whatever that may be, kind of a thing. Cause it may be a movement piece where I know depending on the path of travel is going to be crappy for the next 15, 20 minutes. But then I know it's smooth on the other side of that, and I just need to get him through this without adding on a bunch more stuff, kind of a thing. So yeah, again, depending on your situation, what you have, what you've got in the bag, how do I approach that, kind of a deal. Yeah, absolutely. Yeah. Yep.
Another thing, when I am able to bend somebody's arm hard enough that they actually do use some kind of morphine or longer acting agent, they also think about like, well, what other drugs can I use to kind of alleviate the symptoms of it, right? So like they're worried about the blood pressure. So they're like, can I just use some epi to keep them up, or some other things to kind of affect
No,
to alleviate the side effects. Yeah.
no.
Usually I tell them that that's not what you want to do.
Mm-mm.
But have you found in your practice, like, hey, like ondansetron, nobody remembers ondansetron until they start puking, then they remember. I would say that's definitely one I would use. But like antihistamines or any of the other things, have you ever found them useful or worth doing?
Well, so, again, from a couple of different angles, it's like, no, you don't want to do anything like epi. But because if you're doing something like that, they didn't need the morphine in the first place, that kind of a deal. And if something like that was going on, I'd be more apt to grab some Narcan and start to reverse it. And that's a whole nother, kind of a thing. But in terms of like, are they itching really bad? Are they, doing something along those lines? It's just annoying. Benadryl can, low 25 milligrams of Benadryl can help. It would add in some sedation as well, with the Benadryl, which can actually, help in a little bit of a different kind of a way. Anytime I'm going to move somebody and I'm using narcotics, and in movement, I mean, like I'm carrying them, driving them, flying them, putting them on a boat, any of those kinds of things. Typically I'm going to add in, Zofran ondansetron. Just because of the fact I know they're probably going to puke. And, back in the day we had, scopolamine, and I think scopolamine still discontinued. That was great for the motion side of things. And it was very cardiovascular stable, and it had sedative effects. But so that's kind of not the option there. But, Benadryl could help with some of the itching, that you see with morphine and things like that. But, most times you don't have to. And to be honest, if you did see a big blood pressure change because you shifted from fentanyl to morphine, they ain't getting no more morphine. You know what I mean? I'm not thinking about, trying to ride that rodeo. We used to call that like the anesthesia rodeo. I'm giving this, now I'm giving this. I'm giving this. No. If I did switch them over to morphine and all of a sudden, boom, I saw some kind of a big blood pressure drop, they ain't getting no more morphine. And I might have to, give them something like Benadryl for the histamine release. But I'm probably just going to try and ride that out, go back to, ketamine, which actually will typically maintain or raise their blood pressure a little bit, or keep them on fentanyl, which is, for the most part, very cardiovascular stable. So, yeah.
That definitely makes sense.
Yeah.
Between morphine, hydromorphone, I've heard, one of them, like let's say morphine works on one guy, it doesn't work on another. Like, have you ever experienced this where a person just has a flavor that they like?
A little bit. Here's the funny thing. I've talked to people that have had both. And a lot of times, talk to people, whether it's after surgery or they had some procedure, and for some reason, and sometimes, a lot of times we would use it like coming out of surgery a lot of times to see what people's perception of, was morphine perceived better, or was Dilaudid perceived better. I'll just say this, and I don't think there's any scientific study on this. So this is kind of, this is more anecdotal from the side of the house, but a lot of people have said, they don't know if morphine worked any better than Dilaudid, but they were so jacked up on Dilaudid, they just didn't care. I heard that multiple times. Like, dude, I don't know if Dilaudid cured the pain any better, but I know that I just didn't give a shit on Dilaudid versus when I had morphine with something else. I have heard that like multiple times with people that, have had both and actually in different scenarios. Like, they came in for one thing one time and they got morphine. And then the next time they came in for something else and they had Dilaudid. A good friend of mine who was also an anesthesia provider, I'll just say Pete. He said that specifically, very specifically in those words. I don't know if Dilaudid works any better for the pain, but man, I just didn't care, that kind of a thing. So I can see why people, might come away with saying like, oh, well, Dilaudid's so much better. It's about the same. It's just like you said, it's a different flavor, I guess, so to speak. But, I know even my wife had a back injury years ago and, they had given her morphine for it before. And then somebody shifted and gave her Dilaudid and she was like, oh my God, way, much better. And it was like, okay, for her, it had that same, and I asked her the same question. I said, well, was it so much the pain or no, I just didn't care anymore.
Okay. That's
just like, okay.
Yeah. I'll take it. I'll take it and run.
Yeah. And they both, you got to remember too, fentanyl doesn't have a lot of, sedative qualities. It's just very clean and very well blocks, pain. But morphine and Dilaudid, not only do they work on pain, but they also have a sedative effect. Okay. And so sometimes that really does come into play where, it may be having more of the sedative effect, one of them versus the other versus the actual pain control side of the house. So again, something to consider. I don't think I would choose one over the other based on that. I think a lot of times, when units have switched, like the Rangers switched to, Dilaudid instead of morphine, there's not a great answer on doing that other than a lot of times, whoever is responsible is, meaning the doc who's in charge of the medics feels more comfortable with Dilaudid versus morphine or whatever along those lines. And that becomes their flavor, so to speak, because, it's a lot of it's what it's what you trained with. And always tell people, it's like, it's very important to go and practice or at least go to the operating room and to the ERs to see how the drugs are working. And I'm not talking about once, you need to see it like multiple times and talk to the patients and see what their experience is with it to understand what 2 milligrams IV looks like or a 0.5 milligram of Dilaudid looks like, and it helps you build that base of my sample size isn't, oh, well, I treated one femur fracture once and every femur fracture in the world is this way. It's like, no, that's not a thing, dude. You're not the expert because you've seen one femur fracture and this is what happened, so getting that side of things and talking to patients and seeing how they react to it can be very important as far as how you learn, but it really is trying to have a tool chest with a lot of good tools in it. But inside that tool chest, let's all be serious. I have some favorite tools and I am the best with those tools. And those are the ones that are kind of at the top of the chest, not the bottom of the chest, right? Top drawer. We used to call that in anesthesia. These are the things in the top drawer. That's because those are the things that I use the most and I'm the best at it, kind of a thing. But, boy, some of those special tools really come in handy if I'm up against it and I'm in a weird environment or back to tools and let's say woodworking or something. I've gone over to a buddy's house and he doesn't have all those tools that I'm used to. And well, what do you got? And he opens his tool chest up and you're like, okay, I can make this work. It's not my best, but I can get the job done using those tools because I do have experience with them. I know how they work, and we're going to get through this, man. You know what I mean? So yeah, food for thought. But I cannot stress enough, really, getting to the operating room or the emergency room over and over again, especially where they're doing sedations and some type of pain control, where they're, you know, depending on the hospital, and seeing, and I'm not talking about like, don't go to the place that's using propofol for everything, because that ain't you. That it's not what you're going to use. You know, don't go to the colonoscopy clinic, you know, because all they're doing is propofol. So well, I saw 20 sedations. Yeah, but none of it pertains to what you're really going to be doing. You know what I mean? Going to a children's emergency room at a children's hospital if you can, where they're dealing with a lot of kids that have broken arms. You're going to see a lot of ketamine and things like that at times. Procedural stuff that helps you build that base to see how people react in those different situations. You know? Yeah.
Is there anything else you'd like to add or we need to put out?
I don't know, about 25 years of experience, but we ain't got that time. No, I'm joking, but really, it's like, telling people, develop a plan. Okay. And what I mean by that is you got to have a strategy, to start with. I always tell people when they're trying to learn things, one of the problems is they try and use rote memory. And the problem with that is they have an answer for that very specific situation. But you're not going to get that, and you're going to get tripped up, pretty quick doing stuff like that. It's way more important to understand the concept of what you're doing and then be able to apply that concept to multiple different scenarios. And that really, really comes from a strategy on how are we going to approach pain in that scenario, much like what we're doing right here. And that starts in the team room, man. That really does start in the team room. Get your doc involved, your PA involved, whoever it is that, that's going to be responsible and having to guide a lot of that stuff. And you guys start to work through those scenarios, maybe once a week. Maybe it's sergeant's time on Thursday or whatever whatever you're doing these days. Let's talk about the scenario, just like what you just did. Hey, what about this? Well, you know what? Let's talk about it. What does the protocol say? And let's walk through that. And then have somebody play the devil's advocate. Okay. The devil's advocate who's there to say like, well, guess what? You don't have any more ketamine. You ran out. Here's what you got. Okay. Let's go through that. And as you start to talk through it, I know the actual casualty isn't sitting there in front of you, but you would be amazed of how many times that you can work through those things, that really help you in the moment, because you don't want to be working through those things the first time under a huge amount of stress with a severe casualty in front of you. Okay. I mean, this, Dennis, you want to have really gone through that multiple times so that when it's in front of you, you have visualized that over and over and over again. And it may not be the exact same thing, but you have done so much to build like, okay, I know what this looks like. Let's start working through the problem. What do I have? And, I've worked through this in a team room 100 times, and it will truly help you make much better decisions in that moment. And it will tremendously reduce the amount of, I guess, mistakes that can be made. And when I say walk through it, I mean this too, before we go, the word notional is not a thing. That is my absolute number one hated word in the world, especially in any kind of scenario working with guys. Is like, well, I would notionally do that. And I'm like, that's not a thing. There's no notionally anything, dude. You know what I mean? You got to prove to me that you know how to draw that drug up. If you're going to dilute it down, show me how you're going to dilute it. And then show me how you're going to actually dose it and put it on the clock. You know what I mean? and work through that over and over and over again so that you're not trying to do math in public, in that stressful moment, because that's where decimal points get put in the wrong spot and you make a mistake. You know, that whole thing of like, well, you know, in that moment, I would do the right things. Like, actually, no, you wouldn't. You know, it's like going to the range and going shooting, you know, like, are you magically going to get a shot group on the day that you're actually in a gunfight? You're actually not. It's going to get a lot worse. And you can't go down to Walmart in that moment and buy a shot group, you know what I mean, to save your ass, you know? So it's very much like that. And, you know, from the shooting world or the jumping world and things along those lines, you know, can be a very high stress environment that it really is the practice will make you a much better provider. It ain't going to make you perfect. I'm not going to say that, but the more that you're able to walk through that, the more you're able to get those kind of curveballs thrown at you in those moments before it's actually the real deal will help you mentally work through that problem and to reduce the amount of mistakes in that situation. So anyway.
Yep. Absolutely.
Food for thought.
Absolutely. Yep. On that note, thank you, Brad. I really appreciate you coming on and talking through this.
Anytime, buddy. It's always great sharing time with you, man.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.